Thank you for really excellent talks. My question can be answered by both or either. When we look at the changes that are occurring in adolescence and related to the forces that are being applied to the joints, are we seeing differences in the prevalence in dominant and non-dominant soccer players, for example?
If I might answer that question first. We looked at that in the soccer players and we couldn't find any association between the dominant leg, whether there is a preference of development of a cam deformity or not. So there's not a preference of association between having a cam deformity at the preference leg, in our study at least.
I guess this depends on the training. I mean, if you do symmetric training, I would assume that there is not a big difference. But we have, didn't somebody talk about differences side by side today? So I think we don't have the data on that. But if you look, there's a paper by Paul Bollet. He looked, and I had that. I don't completely recall the numbers, but when he looks at MRIs, most of his patients have bilateral deformities, and they always have, I think, a dominant leg. So when we find FAI, it's mostly bilateral. It's different to hip dysplasia, which is positional problem during intrauterine growth. If you're in a breech position or so this might be one-sided or single-sided, but I think impingement is mostly bilateral.
I think you mentioned that there was some genetic side of it as well, Dr. Lonig. There's something with, was it a British study you mentioned that had shown that if your parents, your dad and your granddad had similar problems, you would have a risk of that. How about ethnicity? Have you any knowledge about that? We have talked a little bit about that. We down here, at least in the Arabic population, see very little of FAI.
Yeah, that's a good point. We know Asians, Japanese, Chinese, they have a lot of hip dysplasia, but almost no impingement. They don't need hip arthroscopy for impingement problems. They need it for removal of loose bodies or fixation of the labrum. So there's clearly between Asians and Caucasians. I think Caucasians have the highest prevalence of impingement. I don't know even North Africans, whether they are the second highest. I can't say, but I mean, there are studies going on, and I think in the next couple of years we find it. But I can completely agree also, people from here, impingement is not such a big problem, and we've seen the measurements of internal rotation. This is much higher here than we have it in Switzerland. Not because the Swiss are stiff mentally, they are also stiff physically. I hope no Swiss is here.
Do you mind if he goes first?
Sure,
absolutely. Just one remark. Maybe it's having something to be with the sitting in this region. They are more flexible because they have the habit to sit with the legs crossed. So I think that there is maybe something to do with this habit to be on the ground and sitting with the legs crossed. Maybe.
Yeah, that's a good option. I mean, from a biomechanical perspective, this might partly or completely explain the differences in preference between, for example, Asian people and Europe people. Asian people who are all, sitting in a lotus position. And, there are some, in literature, there are some studies related to osteoarthritis. And as a CAM is also a high risk factor for osteoarthritis, they found some SNPs, some genetical information that are which are associated with development of osteoarthritis, and those SNPs are also involved in skeletal maturation. So there might be a link between genetics and development of CAM, but we don't know how large it is. The only study which is out on that subject is indeed a British study who compared people who developed a CAM deformity and they compared it with their brothers. But I guess the association they found was about an odds ratio of 2, and I guess their brothers might have an odds ratio about 2 for having the same athletic activities during growth, which might also explain the difference. So, yeah.
I was showing the data that women don't have CAM deformities. So maybe you say all who doesn't have a CAM deformity is rather female. No, but I think that there are people who are tall, people who are small. I think whenever I was young, I never could sit in certain positions, and it's not that I didn't have the training. I think it's also because some hips are just stiff, and I think the Caucasians, they have these typical anatomy that we don't find everywhere else. So it's very difficult always to say, you must have also that problem in your country. This is more a European, North American problem, I guess, than an Asian problem.
Thank you. Very elegant discussion of a complex topic, so congratulations. 2 questions, if I'm permitted. First, Dr. Leunig, I noticed you referenced a couple of studies in which they looked at total hip arthroplasty patients and tried to determine if there was a CAM lesion. We've had a bit of experience with that and find that the more advanced the OA, the harder it is to tell whether there's, a CAM lesion or not, or indeed, any abnormality that's referenced. And the second question is to Rinchi about inter-rater variability of radiographic assessment of some of these lesions, and what's been your experience, and would you suggest an optimal view such as a done view if in a study moving forward?
First question, you're completely right, and we were even with our Swiss recruits with 18 years of age, we couldn't be quite sure anymore whether this is primary or secondary in some of these young guys. So if you have an osteophyte, you don't know what's the chicken, what's the egg, whether this is a reaction or whether this is deformity leading to a reaction. And therefore, this Goswick study, I mean, it points in the same direction, but I think it's the younger the patients are or the individuals that you look at, the more true is the information that you get. And so I think that this is always a problem, and then they only have AP radiographs. You don't see at all what's happening in the other plane. I think even if you have 2 planes with a perfect done view, I mean, I've shown that anterior superiorly is the area where it happens, so you might miss it. Sometimes you really have 2 nice views, lateral AP view, but on the MRI you see that there's a real big bump, or on the CT scan, but you can't do a cross-sectional study using MRI because that's just not possible. But we have to make, commitments to say, okay, we still live with this limitation.
To answer your first questions, regarded to the quantification of the CAM deformity, I guess, right?
Yeah, the inter-rater variability in your hands, and whether or not a done view is optimal, or what would you suggest?
Yeah, the inter-rater variability of the visual scores were 0.73, and for the alpha angle it ranged between the 0.8 and 0.9, and those are quite high, but that's mainly because we do it as an automatic calculation. We use statistical software for that. We don't directly measure the alpha angle, but we place points only at the anatomical landmark of the proximal femur. That's the only thing we do manually. And then we have software that automatically calculates the alpha angle. So that's turned out to be more reliable. And your second question, in literature, I think that there is not much difference between using an AP pelvic view together with either a frog leg view or a done view. You just have, a slightly different, angle you see. But I guess if you combine an AP pelvic view with a lateral view, either done or frog leg view, you will definitely miss some of the CAM cases. How many cases you miss? Well, it has been reported between the 5% and about 30 to 40%. But if you want to be sure, you definitely need 3D imaging, as Dr. Leunig pointed out, a CT scan or MRI.
Thank you. There are two questions left. We started with the lady, Andrea, and then Dr. Popovic has the last question.
Thanks, Frank. As a up-and-coming researcher, thank you very much for those really inspiring talks. It was fabulous to see and hear. But I'm actually asking this question from a mother's perspective of a Caucasian boy who loves football, who's nearly 10 years old. Rinche, what are we going to do with this information? What are we going to tell our mothers about the athletic activity in our growing boys? And is this new? You know, boys have always played a lot of football. Is this a new phenomenon, or is this something that's always occurred? Are we training our boys too young, too much? Our boys in particular. What are we going to do with this information?
Well, yeah, that's of course it's very difficult to answer, and I definitely don't have the right answer for that. But I can comment a little bit on that. I think we only look at the development of a cam deformity, and I think we show that high impact sports practice, especially when you practice it on high intensity, you're of very high chance of developing a cam deformity, which is a risk factor for OA. But other studies also showed that, for example, high impact sporting activities will raise your bone mineral density, which might be protective for getting a fracture later in life, for example. So we only look at the impingement and the osteoarthritis, but there are much more things. Maybe it's protective for getting a fracture, for example, or this kind of stuff. So I don't have the right answer for that.
I think what we never see, I mean, we look at one part of the body, but I think proprioception, I mean, some people have very funny deformities of the hip, but you don't see them, that they can move very well. So I think this mechanism to compensate for things like that is also there. But still, you're right. I mean, I think from the ice hockey experience, the Swiss made, it's clear that rigorous sports in the very sensitive phase, and we have to find out what is this phase. Is this only between 2 years and closure of growth plate, or is it already much, much earlier? That we have to be a little bit less aggressive maybe with the hips for certain movements. And if it's closed, I mean, you can just, I guess, nothing too much will happen thereafter anymore. So, but we should maybe look for the closure of the growth plate before we start with the adult type of training.
Thank you. Dr. Popovic.
I have one question. All this, we had these high-level athletes who, at 40 years after they finished with the total knee arthroplasty, we didn't know 20 years ago, we didn't talk about CAM effect and so on, but basically, on my observation, these people have done their career playing of high level. They become big stars. The price was total knee arthroplasty in relatively young age. That second things, rigorous sports, professional sport is dangerous. We know that, not only for the hips, for everything. But could we, because we have to take some home message in this moment, can we say that surgery in the guys between 20 and 30 years is advised or not? On the second things, do we, for clearance of young people of 12, 13, 14 years, can we have some advice to give to the parents to push these children in football or not? That is a little bit what we would like implicated in sport to take home message, if it is possible in this moment.
I think it's not possible to give you an answer who everybody agrees on. My answer would be yes. I would say there is a sensitive phase to the hip where I think prevention is more important than treatment. So you might, for 2 years or so, until the growth plates are closed, just don't do the very aggressive type of sports, but then you can come back. Now, the Asians, they're also trained as aggressive as the Caucasians, but they still don't get it. So maybe you have just to compare. Now you can make a study through the FIFA, through here, seeing whether in different countries you might have different type of trainings for these young athletes. And with respect to surgery, for me it will be always good to prevent surgery or to not make it necessary. That means if we can have a screening process, if we can try to kind of leave the growth becoming a normal hip, that would be better than to treat somebody with 30, because not everybody who undergoes treatment will be afterwards as good as he was before. And there's, in these athletes, they don't come when they have the first groin pain. They come maybe after 2-3 years when the joint is already far gone. And this, therefore, I think the outcomes will not be so very good. So I think the prevention should be for all of us the most important thing. And maybe you as a sports team doctors, you can think about that. Is there a difference? Why don't we see it? And just look at the hips and just see, we see it here, we don't see it there. Is there a difference in the training? Is it only genetically? Maybe we are wrong, but what he said is for me very, very, I think, conclusive that the stresses on the growth plate, that they make the difference. And if it's closed, I can't explain why the Asians or people here from Arabia, why don't say they have it? Maybe they just have completely different loads on the hip, yeah? Or it's a selection process, yeah? It's because you only can live here if you can sit under the table.
Thank you.
Thank you.
Thank you, everybody, for your contribution. At 3 o'clock, we have to be back for the next talk.